protruding from the surface of the uterus. A common location is just inside the internal cervical os, where an overzealous pipetter sometimes forces entry into and through the uterine wall. There is an important distinction between fetal mummification and fetal maceration. The mummy results from a relatively sterile death of the fetus. That is, there is little or no bacterial degradation of fetal soft tissues. The fluids are gradually resorbed, leaving a uterus which is doughy with a pitting, tar-like quality to its contents. The uterus is not distended, but is closely applied around the firm, tarry mass which is the fetus. Very little endometrial pathology is associated with this condition, surprisingly enough. And if the mummy can be medically or surgically removed, the long-term prognosis for reproductive recovery is fair. There is little or no offensive odor associated with this condition. Fetal maceration, however, occurs when the fetus dies and its soft tissues are bacterially digested, leaving a somewhat distended uterus containing a foul-smelling fluid and sometimes palpable crepitant bones. If the condition is long-standing, the fluids may be partially absorbed, leaving a smaller uterus which is distended only over the area of crepitance. The prognosis of this condition is very poor, as considerable and often irreversible damage is done to the endometrium. Both of these conditions, mummies and macerated feti, are associated with the presence of a persistent CL. The most commonly encountered pathology of the dairy cow's ovary is the ovarian cyst. These are, as stated, fluid-filled structures greater than 20 to 25 millimeters in diameter and associated with improper release of pituitary luteinizing hormone. The finding of a fluid-filled structure greater than 20 to 25 millimeters in the ovary of a non-pregnant cow should be tentatively diagnosed as a cyst. These cysts may be of at least 3 types. These palpate as overly large follicles, often with more than one in an ovary. They are very thin-walled, tense, and fluid-filled. They will distort the size and shape of the ovary considerably. Some can be easily ruptured by applying mild pressure, roughly equivalent to what might be necessary to crush a very ripe grape. These are pathological cysts. These can be just as large as follicular cysts, although the wall may be somewhat thicker. The lining contains considerable luteal tissue, giving the palpator the impression of a tougher cyst wall than a follicular cyst. Sometimes there will be a rim of palpable luteal tissue at either the base or the top of the cyst. These are pathological cysts. They are difficult to differentiate from follicular cysts. These are also large, fluid-filled structures on the ovary, but generally they will have a subtle but palpable papilla, indicating that they have ovulated. The wall is generally considerably thicker, and there may be a waistline in the ovary at the base of the CL. These are generally considered not to be pathological structures. These may be suspected when the ovary cannot be freely picked up from the normal position on either side of the uterine body. The ovary may be embedded in portions of the bursa or in the broad ligament. The significance of this condition is that ovum transport may be affected. It should be noted that some cows have a short mesovarium, and therefore one should not diagnose ovarian adhesions simply because the ovaries don't travel easily. Abscesses, like cysts, will greatly distort the size and shape of the ovary. Unlike cysts, they will usually be firmer, with perhaps a fluctuant cap. They are often associated with ovarian or peri-ovarian adhesions. Let me make a comment about so-called smooth ovaries. There is a time in every cow's cycle, that is between day approximately 18 and day 5, or day -2 from estrus to day +5 after estrus, when the normally cycling cow will have very few palpable structures. These can be mistakenly labeled as inactive ovaries if repeat palpations on the same cow are not performed. Therefore, the diagnosis of smooth ovaries or inactive ovaries would require repeated examinations to confirm. The passage of an insemination pipette per vagina into the uterus should be done cleanly and fairly quickly to avoid problems associated with excessive straining. The vulva should be cleaned and then a hand passed into the rectum to grasp the posterior portion of the cervix only. The cervix is then pushed away from the palpator in order to straighten out the vaginal canal so that the pipette will not snag on any vaginal epithelial folds. The pipette is introduced through the dorsal commissure of the vulva and passed quickly to the anterior vagina, where the trailing fingers of the hand in the rectum can locate it. With these fingers serving as a funnel, the pipette is guided into the external os. The rectal hand then regrips the cervix in the normal palpation manner and gently manipulates the cervix up and down, left and right, over the pipette. Note that the pipette is not pushed through the cervix, but rather that the cervix is guided over the pipette. For most intrauterine therapy, the pipette would be passed only to the body of the uterus, that is, just beyond the internal cervical os. Note that the palpable bifurcation of the uterus is well beyond the actual bifurcation. It is therefore easy to mistakenly deposit either semen or medication in one horn only. To avoid this, palpate the tip of the pipette just beyond the internal cervical ring before depositing medication or semen.